We never had a podcast at the forum, and I was convinced by Alex, who I had the pleasure of working with clinically, and Alex will introduce himself and his colleague in a minute. There was one practical thing I wanted to say. When usually we are guests in this spectacular palace, we just have a little problem, which is no toilet paper in the loo. And so I normally bring the toilet paper from local supermarket. So we have done this morning. So if toilet paper runs out, don't feel that you have to ask people in the palace. Ask me. I won't feel diminished for being the toilet paper provider. We have also asked to put some soap because I realized, at least in the ladies, that there was no soap. I can't come in the gents. So please, gents, if you have any complaints about your side of the loo, come and tell me, and I will send one of you in to sort it out. So otherwise, I hope you're all happy and enjoying this palace and the content of this morning talks. We are waiting for one of our podcast panelists who is in the loo. So does he know how to come back? Searching for toilet paper. Okay, well, too bad then. So maybe, Alex, you can introduce yourself and what this is about, and then when Tony comes, I'll introduce him.
Sounds good. Hi, everyone. So my name's Alex, and I'm a registrar psychiatrist at the Maudsley. And with Rebecca, who's a co-trainee at the Maudsley, and our other co-host, Anya, who unfortunately couldn't be here, we've been producing podcasts in SLAM for the past couple of years. South London and Maudsley. And really, it's podcasts where we interview experts and those with lived experience of mental health conditions, all about psychiatry, psychotherapy, and related topics. And we're very pleased to be here at the Mediterranean Forum. Thank you, Marta, for having us. This is our first live podcast. So what this means is essentially we're going to be recording a conversation here today, which will then go on our podcast in a couple of weeks. And that will give a chance for thousands of listeners all across the world to listen. So no pressure. We're very pleased to be continuing the conversation about insight with our esteemed panelists. And Rebecca, would you like to, I think before we start to frame the conversation a bit, insight is obviously a very interesting topic. It's something that I think we all value, we all crave insight, both as it relates to people with an actual mental health condition, but I think everyone can see that there's a lot to be gained from insight, and we seek it out. You know, we seek it out from our doctor's consultations, we seek it from our therapists, from works of art. Insight is clearly something valuable, but maybe there's dangers associated with insight as well. So maybe to kick off the conversation, Rebecca, would you like to ask the first question?
Yeah, thank you, Alex. Hello, everyone. Following on from what you've said, my first question is for Professor... Oh, sorry.
So I think you had the pleasure of meeting Professor Tony David, and you know how much he's interested in insight, so I'm not going to go there. And then we have Professor Anton Gregg and Professor Eric Chen, and actually you're going to hear them both today in the main lecture. So Professor Eric Chen will represent not only what is happening in a different part of the world, such as Hong Kong, but also what is the view of developmental and longitudinal trajectory of psychosis, because he has led some of the most representative longitudinal study of outcome of psychosis. And Professor Anton Gregg, who comes from Malta, so again, a different part of the world, and is their head of psychiatry, is also one of the main organizers of the forum, is part of the committee because he represents a slice of the Mediterranean, apart from being a friend. And then we are going to have in and out Professor Argyris Stringaris, who you have now met, because we thought that insight is not only about adult life, which is what you have heard, but there must be something that happened about insight in childhood. And Argyris represents, you know, the knowledge of child psychiatry at this conference.
Thank you very much. So my first question is for Professor Tony David. You spoke a little bit about potential negative impacts of lack of insight. But do you think that there's a possibility that there's a more complex psychological mechanism driving lack of insight in people, for example, with psychosis when they're unwell, that might be more protective when they're unwell?
I think it's an important question to consider.
I'm not sure that microphone works. Maybe. Or does it?
Can you hear?
Yeah.
Yeah. So, and so the idea is that it's rejecting the idea or resisting the idea that you have an illness, that there's, something wrong with you, has a defensive function. And I think that there's a lot of truth to that the person is trying to preserve self-esteem by resisting that notion. And I think there is some empirical work that bears that out. But I think it does have to be balanced against the consequences of poor insight. And I think you can manage to do this if you're a good clinician. So the adverse consequences of poor insight, most obviously, is if you reject effective treatment or help in any way. There's nothing wrong with me, I don't need your help. That could be very, very damaging to you. So you don't need the person to say, I'm a diseased, disordered person, I'm worthless, I'm throwing myself at your mercy. No, you could say you're who you are, you've suffered from a condition. That doesn't mean you're basically a different kind of person. You're who you are, and your self-esteem is important. On the other hand, why deny yourself the chance to have some treatment which will make you feel more like your real self? So I think it's the way that you, the clinician or therapist, frames treatment as a way of not going against the person's identity or their self-esteem, but rather you're on the same page, you're pulling in the same direction. You're trying to enhance the person's autonomy, their individuality, their esteem. And you do that by saying, if you're plagued by hearing voices all day, that's not going to help you achieve your goals. So I think there needn't be a conflict between improving insight and maintaining the person's esteem.
So I guess this is a problem we all run up against as clinicians, which is I think everyone, when they start working clinically, they realize you can't force insight on someone. Insight can't be a bulldozer. That tends to make people's defenses go up. So maybe if I could direct a question to Professor Grech, when you're working clinically with patients, how do you approach the consultation to help people develop insight for themselves, both about the condition itself, but maybe about treatment as well?
First of all, when you're approaching a patient, from the very first second, you're going to influence how you're going to project the idea of insight by your attitude. You need to be empathic, welcoming, and the patient needs to feel at ease in your presence. And I think that's very important for many aspects, including when we arrive to the point of insights. So that's basic. Once we don't talk about insight in the first couple of minutes of the consultation. So with time, you understand what the patient is. You might have known him for some time. He might be a new patient. And then at one point, towards the end of the consultation, you start to discuss how I can help him. That's how I approach it. I told him, Mr. X, how can I help you? I'm a psychiatrist, as you know. I can only help where there are conditions. That's my profession. And at that point, I try to tease out if the patient is aware that he has an illness or not. If not, if he's not aware, I try indirectly. And especially it's the first consultation. if the patient is suffering, I don't know, from hallucinations, and it's difficult for him to understand that these are hallucinations, but they are causing him to be anxious, I'll tell him, I can help you to be less anxious. So it's not, as Professor David was saying, it's not sort of a direct confrontation, but you can go to it indirectly. As I said, with your attitude, it's very important, and it's a build-up. And one of the nice things about practicing psychiatry is that we got to know the person. It's not a one-off consultation, it's a process. So it doesn't mean that I need to make sure that the patient has insight from the first consultation. But it's a process that it goes along as I got to know him better with the treatment, etc. So in a nutshell, it's not a question of now it's time for insight. But it's a process that starts from the first second you encounter the patient.
Yeah, and I think, so it sounds like you're trying to occupy the patient's frame of reference. And I think you're trying to resist the urge that we all have as doctors to enforce the idea of what's right or what's scientifically or objectively true.
Exactly.
And
you have to see it from the side of the patient as well. Because it's what's best for him. And you need to see, you need to put yourself in the patient's shoes and see what you're talking about, what you're telling him, and how he is receiving it. And that also helps insight. It's part of the process.
Yes. And when I think about this, I often think that I'm not entirely sure that our brains really evolved to understand what we could call objective reality. Our brains were like, it seems to me that beliefs really are often just a vehicle for an action which could be useful or adaptive in some way. Professor Chen, would it be fair to say, do you think that our brains, that a kind of scientific objective way of thinking is very foreign to our brains and it's something we really have to struggle to come to terms with?
Yes, indeed. Can you hear me all right? Yeah. So we assume in a very simplistic manner that people are just rational beings. And if you give them this information, they will come to that conclusion. And such action will follow. But we now actually have a lot of knowledge about how human beings make decisions, how we form our beliefs, and we are far from being simply rational. Okay, so our sort of first generation psychoeducation efforts assume that if we give this information as dopamine and so on, then people will understand and they will act accordingly. Now that is probably inadequate. So we need to understand that people often have multiple levels of trying to make sense of their illness. They may listen to the doctor. They may also look at their other knowledge and cultural sort of system in order to make sense of their illnesses. One only have to look at help-seeking information, and you will realize that people often seek help from multiple pathways. And when we work with patients to try to facilitate their coming to terms with the illness, I think the first thing is to give up a very simplistic, rational approach, and then secondly, to respect the other approaches, and also try to, I think, like Anton has said, to involve in a dialogue. We have to recognize that emerging from a psychotic episode is a very complex and challenging experience. That some of your experience, direct, true, real experience as you thought for the last few months or years, and suddenly you have to face that maybe they were the result of some other processes. Now that is absolutely not easy to come to terms with. I think a good clinical team, good clinician will have to be aware of that effort that patients have to be making. The other thing I think relevant to this is that there is actually some signal that good insight following first episode psychosis is associated with depression and even suicidality. So I think that actually reminds us that at the same time as we are facilitating people to make sense of their illness, there should be support and a lot of support in helping them to negotiate this difficult process.
I think that's a really interesting point, that more insight may be associated with negative outcomes. Is it paramount to develop insight in order to recover from a psychotic illness? Or can someone recover and make a full recovery without any level of insight? I don't know who wants to answer that.
Well, first of all, I think the idea that gaining insight leads to suicidal behavior, again, I think one should be a little bit skeptical about that. And we've studied this a little bit as well. So again, when people unfortunately take their own lives who've had a psychosis, it's usually in the context of breaking contact with the clinical team. It's usually in the context of stopping medication. And it can be quite abrupt. And those are red flags. So I think and we know that insight is very related to accepting treatment and help, as we've been saying, as long as it's formulated in the right way. So one's got to be quite careful about that. It's a common belief, but like all these beliefs, we've got to question them. So in terms of, well, do you have to, as it were, renounce your previous beliefs and behavior in order to be fully recovered? No, I think that's completely the wrong way of looking at it. People will come to an accommodation and they're in the sort of 40 or 50 years ago, people described different patterns of recovery. The American psychiatrist Tom McGlashan was very influential on this, and they had a phrase called sealing over. And so it was the idea that a person had just decided to wrap up their previous behavior and beliefs. They didn't really want to examine it too closely. They didn't really want to get into a discussion about what happened, why it happened. It was wrapped up, it was put aside, and the person had decided to move on. So the purists will say, no, until you've really confronted all of that stuff, you're not really going to move on. No, I don't think that's right. I think people have different ways of moving on. And for some people, it's simply just to set things aside and start afresh. And if that works, then that's great.
So there's something just about the respect for a way that someone chooses to recover, if you like. And you use the word accommodation, which I think is a nice word.
I think that's right. I mean, I think you might say, well, if the person gets into difficulties later on, maybe it's a problem that those difficulties are sort of still there but just have been set aside. Well, we don't know.
Yeah.
Maybe that's true, but I think patterns of recovery are very as individual as there are people.
Yeah.
And we shouldn't have a clear sense of what's the right way and what's the wrong way.
Sorry, I really wish to underline this, Tony. If I have a patient who was psychotic, and then he started to take treatment, things have improved, delusions are not present anymore, but he'll tell you, but I still think that, for example, I have had persecutory delusions, that people were against me at that point in time. They're not anymore. But I don't really argue with him.
It won't accomplish anything.
What is important is that now he's better, he's having a better life, and he's well and happy.
Yes.
What's the point of arguing if they really were against him, unless it's influencing his action now?
So you're putting quality of life squarely as the goal.
Yes, and the purest attitude, which is he is not cured unless he is 100% sure that they were not against him. I think we should not aim towards that. We need to see the whole picture.
Yes. Unfortunately, we're a bit short on time, but one thing I wanted to ask as we wrap up is, Professor David, you talked about metacognition in your presentation, the ability to be aware of your thoughts. Are there any activities, practices that have been proven to help someone, or even in your anecdotal experience, can help someone improve their metacognition? I'm asking things like maybe mindfulness, meditation come to my mind, but is there anything you're aware of that can help with metacognition?
Well, there are a number of therapies being advanced that explicitly try and enhance metacognition, metacognitive therapies. There's in Germany, I'm trying to remember his name, Stefan Moritz. Thank you, Eric. Yeah. So it's a whole package around helping people, first of all, appreciate how perceptions, everyday perceptions, can be mistaken. How if we approach a scene with certain preconceptions, we may see it very differently. So I think the idea is you can train yourself to be a bit better at metacognition, to be able to stop and reflect on your thinking processes. There have been some preliminary trials that suggest that this might be effective. Of course, you really need to do very large-scale, very controlled trials to show that it's really helping. But I think it's a very good avenue. It's a very good new way of approaching the issue.
Yeah, thank you. Marta, there was a question.
Well, it's a very basic question. Is that does insight have an age?
Thank you. I should say that I am representing child and adolescent psychiatry here, but I'm not omniscient, and I don't, I should be humble because I don't know everything about insight. I'm not a psychosis person either. There are a couple of things to say. The first thing is that we don't know enough because we don't ask young children enough. We haven't asked them enough. So the problem we have as a discipline of what some people call epistemic injustice is particularly true with children and adolescents. That's one thing. The second thing is it's hard to do partly because of the psychometric properties of child report. So there is a reliability issue as you go down in age. Those things can be partly overcome. It's a question of how exactly you do it. The third thing to say is that as far as I'm aware, and if someone knows of better data, they should please correct me, most of the information we have about this comes from OCD. And in OCD, there seems to be some decent evidence that age is associated with less insight. Though in absolute numbers, absence of insight, even in OCD, seems to be fairly rare. But there is an association, a fairly robust one and reproduced one, as I understand it, there. Interestingly, it is associated also with family accommodation, which in this context means a family that gives in to the symptoms of OCD as well and facilitates some of the rituals. Which is very interesting. Again, as I think you mentioned earlier, insight is, shall we say, a dynamic concept, probably a little bit like capacity. So you have to ask about it in the particular context, in the way you frame the question, so that you don't negate the other person's, personality, particularly when they're an adolescent, I guess. And take these things into account. I think it's a very fruitful area for research. So I hope that someone will do it. Will do it soon.
Thank you very much. Is that all we have time for, Marta? So that's all we have time for. Insight is a wonderful topic, and we could go on for 3 hours. And we'd love to have you all individually for your own dedicated episode. Thank you very much.